Welcome to the Demonstrating Implementation Excellence stream at the SNOMED CT Expo 2021. My name is Linda Bird and I am the Implementation Support Lead at SNOMED International. Today I'll be moderating this session for you. Please use the discussion forum on your device to type any questions you have for the presenter, and then all questions will be answered at the end of the presentation. I'm now pleased to introduce Matthew Valentine from Curate Health in New Zealand, who will be presenting Implementing SNOMED CT in African Communities. Please go ahead, Matthew.
Thanks, Linda. Hi, everyone. It's evening here in New Zealand for me and morning for Olivier in Rwanda, and I'm guessing we have everybody in between. My name is Matt Valentine. I'm an emergency medicine doctor by training, and I'm the co-founder and chief medical information officer for Curate Health. My colleague and co-presenter, Olivier Garcia. He's the program manager for EJO Health for Rwanda and East Africa. Today, we're going to present to you the implementation of our SNOMED CT-powered app for Rwandan community health workers. This presentation is a follow-up to the clinical webinar that Olivier and I did for SNOMED 6 months ago. So I'll first quickly review the setup to this project that we talked about in that earlier presentation. We first talked about the backstory to our company, how in 2020, Olivier made a video for the HL7 Fire Dev Days about the work he was doing in Rwanda and Burundi with a company called the Sovereignty Network. That video was seen by Rohini Bana and myself, the co-founders of Curate Health in New Zealand, while we were working on a SNOMED CT and Fire platform in New Zealand. We wanted to be a part of that work, and we learned that someone that we knew, Dr. Mike Bainbridge in Sydney, was working with the Sovereignty Network. He introduced us to the CEO of the Sovereignty Network, Hamish MacDonald, who happened to be in Auckland. With this serendipitous coming together, we merged our companies and got to work. Back in Rwanda, Olivier had developed a relationship with the Remera Health Center, the largest health center in Rwanda, based in the capital of Kigali. A large part of their work involves overseeing community health workers, a model of healthcare delivery that is very well developed in Rwanda. The system initially started in 1995, and today there are over 45,000 community health workers in the country. Working on a volunteer basis, they provide services such as maternal checks and age-specific assessments for children. Each worker will be monitoring 100 to 150 families at any one time. Now, these community health workers, on average, have about 3 months of training. So their scope of practice is highly circumscribed and protocolized. As well, as I mentioned, they are overseen by doctors and nurses at health centers, and their protocols have a low threshold for referring patients back to the health center. However, they can treat and dispense medicine for common problems, such as malaria, diarrhea, and pneumonia. Currently, that workflow is entirely paper-driven, with multiple forms and ledgers. Here's an example of one of the most common forms for assessing a sick child that's been translated into English. There is an identification section, an initial assessment section with danger signs which mandate immediate transfer to the health center, a treatment and medication dispensing section, and a section about preventative care and counseling. Then when the community health worker reassesses the child in 2 to 3 days, there is a review section, again with danger signs, a diagnosis and disposition section, and then final advice and sign off. So although there's a lot happening on this form, you can see that the data structure as well as the workflow is pretty straightforward. But with everything on paper, collecting, consolidating, and analyzing information is practically impossible. So the process was ripe for digitization. Olivier demonstrated the burden of the current paper system in this video.
Today, I would like to present to you how technology can support clinicians, community health workers on their workflow. Do you really understand their daily challenges? For this video, I would like to focus on community health workers' forms, family planning, pregnant women, delivery, child health forms, represents more than 6 meters, more than 16 kilos to carry, more than 100 manual records. All that can fit here. And the most important part, help the community have workers to deliver the right treatment.
Currently, there are no SNOMED member nations in Africa and relatively few affiliate licensees. With this alignment of interest, they agreed to sponsor a project to begin to digitize the Rwandan community health workers' paper process. That was pretty much where we were 6 months ago. Since then, the team has been very busy, and we are proud that we have gone live in the first stage. I'll go through some of the challenges we faced and how we've met them. Obviously, like for everything else in the world, COVID has caused considerable problems. We've not been able to get anyone into Rwanda to support Olivier, who has coped magnificently with having to fill just about every local role in a project team by himself. Even at the last minute, problems would pop up, like when one of the officials whose signature we needed to go live was unavailable because they had contracted COVID. This also impacted on our ability to help the clinic transition from a paper to a digital workflow and to do all the business analysis that came from that. This work was spread across multiple countries and time zones, from Rohini and I in New Zealand, Mike in Australia, our great dev team in multiple locations in Russia, and Olivier in the clinic in Rwanda. We did get to a good result, but it was slow to get there. To help these issues, we did eventually find a great project manager, Desi Nair, in South Africa. Although he only recently has had his first trip to Rwanda, just having someone in the same time zone was a big help. We made a fortuitous discovery in the analysis of the Ramera Health Clinic's forms workflow that they are based on the World Health Organization's guidelines for community health workers. This provided a very strong clinical framework to base the development on and has allowed us to ensure that our forms are compliant with the WHO recommendations. Making the app work in different languages was another challenge. Both the clinical terminology as well as the general interface needed to be multilingual. Unsurprisingly, there is not a Kenya-Rwanda language set for SNOMED CT, or at least not yet. But our developers found a useful utility to include in our app to make switching between languages easy, and working with the clinicians at the Ramera Clinic, we have translated an initial set of SNOMED CT concepts from English to Kenya-Rwanda. Both of these translations can become the foundation of a Kenya-Rwanda language set. Our team predominantly uses Apple iPads as our preferred device. Getting several iPads shipped from South Africa to Rwanda in the midst of a global pandemic was a bit of a challenge, but we did get them there eventually. Our software is developed with React Native, so essentially we can compile the app for iOS and Android simultaneously. In the future, we will look to make more use of Android devices. We also found it helpful to use device management software to help keep all the tablets up to date and synchronized. We had initially believed that we would need to make our software capable of offline use with a sync when connectivity was restored. It turned out that Rwanda has great mobile data coverage, so we did not need to implement this feature for this stage. We do still have it in our roadmap, though. Finally, training the community health workers was a critical step. Olivier's background is in education, so he organized a very thorough training program for the community health workers, which also provided great feedback to us. This brings us to where we are today. Olivier summarizes the journey well in this next video, which will also show you the app in action and with our very first patient.
Let us begin with drilling down on the development and preparation process. In Rwanda, the journey with SNOMED International started in January 2021, when we started to build the Hejo Health Program with Ramera Health Center. The first step was building FIRE and SNOMED's compliant electronic forms in French, English, and Kinyarwanda. The second step was to identify in Gasabo district areas where we need offline mode. The 1st February, Gasabo districts granted our request to build electronic forms for community health workers with Remera Health Center, Rwanda's biggest health center in the Gasabo district, representing 5% of the population in Rwanda.
Work closer with Azure Health, we offered an office at the administration block of Remera Health Center to achieve our dream of paperless workflow for community health workers and nurses.
Morning. As you are all aware, Gasabo District has always been supportive to improve health. Let me first introduce myself. My name is Alphonse Tarinwa. I'm in charge of public health at Gasabo District. Last time we met here because the Gasabo District administration is supporting the Azure Health program. We request community health workers to embrace this technology because we are lucky to have an opportunity to solve health challenges in our district and to reduce errors sometimes identified during children consultations in our villages.
Nabyumvise neza uburyo bwo gukoresha ikoranabuhanga rya Ejo Health. Ngaho nimufate advantage mbona polisi. Mbere na mbere duhera ku mwirondoro w'umurwayi.
During the consultation, I first record the client profile. Then we capture the illness in Azure Health. There are 4 categories of illness: fever to track malaria, cold, and cough, where we identify pneumonia cases, then diarrhea. And in case of something else, we record it here in other illness. We screen danger signs that are related to the current illness. Then we test and treat according to illness algorithms that will reduce errors and time we spent on consultation. What took me 20 minutes before can be done in 5 minutes using Azure Health. What I love more about Azure Health, necessary calculations are now easy and reports are automated.
Jeanne Pokwizera is filling an ICCM form, Integrated Community Change Management, used by community health workers to consult children between 2 months and 5 years old. The maternity module has also been developed, and this program will launch soon. The Azure team who worked on the development is composed of clinicians, healthcare software developers, fire and SNOMED experts from around the world, including some of the best individuals in informatics and digital health. Working with the Remera Health Center, we have effectively managed to map and digitally customize the Ministry of Health community health workers forms in Kinyarwanda, French, and English, aligned with the World Health Organization's guidelines, and incorporates SNOMED international codes and terminology.
I think any clinician or client in the audience could recognize that that little girl in the video was indeed sick. I can assure you that she has done well and that her mother was consented and reimbursed to be in the video. What have we seen for results in our implementation so far? At this point, with initial use, we are already seeing significant process improvements. The community health workers are finding the system much faster. Like we heard in the video from Nipo, it only takes about 5 minutes instead of 20 to do a form. It's easier to use as well, with a more logical and streamlined layout and flow, and also weighing significantly less than 16 kilos. It is also safer. For example, The user is forced to document all the danger signs so that none can be missed. Medication dosing is also no more having to look up doses in a table and potentially misreading them or missing a line in the table. All these process improvements are realized while also capturing high quality data. Structured SNOMED CT concepts directly packaged by FHIR structured data capture forms. This creates a powerful resource with which to start measuring individual and population health benefits going forward. This aligns with the African Union's digital strategy for 2020 to 2030. Our next steps include furthering our maternity care forms using the WHO guidelines. The community health workers do a great deal of antenatal care that we want to support. Ideally, we'll expand the type of clinicians using EJO to include nurses and midwives. We are looking to provide a FHIR API into our platform so that other systems can integrate readily with our data. And we are looking to expand our clinical footprint and work with additional funding partners to sponsor the ongoing work to bring this cutting-edge digital technology to healthcare across Africa and across the globe. As we move forward and continue to extend EJO Health within Africa, developing an approach with which to progress from observed outcomes to measured outcomes will be important and opens doors for collaboration with regional, national, and international health policy and decision makers. That concludes this presentation. Olivia and I are happy to answer any questions, and please also see our website for further information.
Thank you very much, Matthew and Olivier, for your very inspiring presentation. Could you all please give us one moment while we switch over from our pre-recorded content to our live session so that Matthew and Olivier can address the questions you've submitted. And also please note that this session will be available on the event platform for the next 3 months. So, as I said, please look at the bottom of your screen and you'll see a live Q&A button. If you have questions, please use that live Q&A to submit them right now and we will answer them. And while we're waiting for those live questions to come in, I was wondering if you'd like to give us an update on the project, Matthew.
Yeah, thank you. Thank you, Linda. So that was recorded 2 weeks ago. And last week, we were asked by the Rwandan government to stop working on this project, which was something of a disappointment. We did have approvals all the way at the local levels and district levels, well within the authorities of those officials. But Rwanda is working on a broader project to provide software to their community health workers that will be FHIR-based, like our solution, but we believe will be based on ICD codes rather than SNOMED. So that is a bit of a disappointment because we had really, we think we had really demonstrated the power both of the product, but also of the working relationship with the Ramera Clinic, and we're looking forward to spreading that. But that's all right, and we are in a good place to look for other partners to work with, and we're very open to working with other members of the SNOMED CT community to help implement this project elsewhere in Africa or elsewhere in the developing world.
Okay, so looking for further opportunities to roll out the wonderful system you've developed. Could you tell us a little bit more about the clinical guidelines that you used within the system?
Yeah, like you said in the video, it was a I guess it shouldn't have been a surprise, but it was a pleasant discovery that the child health form that the Ramera Clinic was using under the name of Integrated Case Care Management was based on a World Health Organization child health guideline, and that allowed us to use that to flesh it out a little bit more. But it also we learned it was a subset of that whole guideline, which gave us a good introduction to how to take such a guideline and localize it appropriately for the specific implementation. WHO has a few other guidelines that they have developed specifically for digital adaptation, and that includes antenatal care and family planning. And so we'll be looking to use those for to help guide further development and forms and pathways within our application on our platform, because they have they have done a lot of great work on how to on what various requirements are, decision support, data elements, etc. And so combining that with what we've learned about appropriate localizations for workforces that maybe don't have the full breadth of what the WHO guidelines specify, we believe will be a even more powerful combination.
Okay, thanks, Matthew. And a couple of questions are coming in. Firstly, could you please talk about some of the challenges you've faced while implementing the project?
Sure. So time and distance and COVID were probably the biggest, and working. We had the people at the clinicians at the Romero Clinic were fantastically enthusiastic and really dived into this project well. But it was a new digitization of a paper process was a new activity for them and for Olivier. So it was difficult to help support that in remotely. You really wish you could get into a room with a couple of whiteboards and really just hash everything out. And instead, that had to happen at late in the morning or early in the evening or late in the evening for everybody involved, and using remote tools and in multiple languages. So that was quite a challenge. That was a challenge. But we got a lot of experience from it, and we think we do it. We've learned a lot to take to other sites to do going forward.
Thanks, Matthew. Yes, I'm sure we all share those experiences of wanting to get around a whiteboard in a room and discuss things. The next question is, any tips on how you produce such a user-friendly app? So presumably from the user interface perspective.
Sure. Thanks for the question, Alistair. Again, a lot of the credit for that goes to the Romero team. They had put a lot of thought into how their community health workers interact with the app. And although, like I said, even though it had a WHO guideline underlying it, the arrangement of the elements on the screen, the order in which sections came up, a lot of that is what the Romero clinicians, with some agile back and forth working between them, us, and our dev team came up with. Further from that, a lot of the EJO platform, a lot of it is based on our underlying, or almost entirely based on our underlying Curate Health platform, which is what we've used to develop some software for community allied health practitioners in use in New Zealand. And so we'd have just experience with UI, user interface and user experience from that. But it is something that we want to improve. Everything that you see on that app is the forms are based on the FHIR structured data capture technology in FHIR version 4. And we think it works well, but we'd like to make it we'd like to make it look even better. So some of our next development steps include making it easier to design those elements and have more design in general around it to make it even more approachable for other in areas that are transitioning from paper to digital.
I love the way you talk about it being very clinician-driven user interface design, where the clinicians drive that and work with the UI specialists. So that sounds like a very great approach, and hopefully that answers Alistair's question. Thank you. Are there any other questions coming in from the audience? I can't see any at the moment.
Don't see any, no. So, yeah. So, like I said, we're fortunate in that we have a couple of connections elsewhere in East Africa that we'll be looking at. But like I said, happy to talk to anyone with other ideas and who thinks that we could be of assistance in some place that they know of.
Wonderful. Thanks, Matthew. And one final question from the audience. Did we hear correctly? Is React Native used for the app?
That's right. So although, like I said, we do most of our work with iPads, the Android version is basically has feature parity with just a different compiling of that, and going to the web is just to a standard web interface is pretty straightforward as well. But you know, as a clinician myself, I really like using tablets because it's something much that you can use in a clinical environment interface, and it doesn't come between you and a patient. Any times when I've used, had to use computers, you either turn your back or at least your side to the patient, or you have a cart with a laptop sitting on you between you and the person you're trying to care for. And I think in that video where we saw Nipo talking with the woman and her daughter in that video, and you could see that he was facing her, taking notes, and they were interacting with each other and in real time while he was recording the information. So we really like to put our software onto tablets to allow that sort of interaction to happen.
Well, thank you very much, Matthew, for that wonderful presentation, wonderful example of SNOMED being implemented within a project. Do you have any final comments before we wrap up?
Just a final one to thank SNOMED International for the support of this project. I think that was mentioned a couple of times in the video, but it was a great support, and I shows the vision that I think SNOMED International has to promoting it, SNOMED CT, to be a truly global standard in terminology. And we're really happy that we've been able to play a part in that and look forward to doing more.
Wonderful. Thank you so much, Matthew. And thanks very much to the audience for your participation as well. I hope everyone enjoys the rest of the Expo and the other presentations as well. So thank you very much. Bye for now. And thanks again, Matthew.
Thank you.